All right, and hi guys, welcome back to the On Call podcast. My name is Casey Albin. Again, I'm a neurointensivist at Emory University.
And I'm Salia Farrokh. I'm the Neuro-ICU Clinical Pharmacy Specialist at Johns Hopkins Hospital.
Thanks so much for tuning back in. As a reminder, On Call is a continually updated textbook from the Neurocritical Care Society and is available online, and it also earns you CME.
Remember that you can get access to the full chapter by checking out the link in the show notes. We're also so grateful for our sponsors who make this podcast possible. And now we have a note from our sponsor.
Ceribell point-of-care EEG with AI can help you rapidly detect or rule out non-convulsive seizures at the bedside 24/7. Visit ceribell.com to learn more.
All right, jumping right back in the first episode, we talked about how to recognize status epilepticus and when to suspect non-convulsive status.
And we really emphasized how it's key in the effective treatment depends on really recognizing that the patient, first of all, is in status, and then you must get the appropriate dose, which is going to feel higher than what you're used to giving, to the bedside as quickly as possible.
Exactly. So Casey, what if seizures don't stop or the patient is not returning to baseline despite getting, the right doses, which we talked about, up to 4 milligrams of lorazepam, IV times 2, or another first-line agent?
Yeah, this gets into a really challenging situation. We know that the patients who do not respond to the first-line agents, we know from the ESET trial that with the second-line agent, there was only about a 50% chance that they were going to have seizure suppression with that second-line agent. And so when we have patients that kind of continue to progress despite getting the first-line treatment, these are patients we really have to be concerned about. I think one of the things that the on-call authors really emphasize is that we don't really have a data-driven approach for what to do with these patients who continue to seize through the first or second-line agent. The big question always becomes like, when do we pull the trigger on intubating the patient and moving to anesthetics? And I think for convulsive status epilepticus, I think it's pretty obvious that we need to take control of that situation. Get the patient that first-line benzodiazepine as soon as you possibly can. Use the appropriate dose. If the patient is continuing to have seizures through that, I think it can be an appropriate strategy just to move towards intubation with anesthetics to suppress the seizure activity. Ideally, you get that second-line agent in while you're doing all of this, but to be honest, sometimes it takes a while to get those second-line agents to the bedside, and that's not the patient that we want to continue to be seizing. The thing that I think is actually a more common scenario is that the convulsions stop after they get their first-line agent, but the patient is not coming back to baseline. And this is tricky, and I think it really does involve some good clinical judgment, because you have to determine, is this a patient that's postictal and it's just going to take some time for them to come back around, or is this a patient who's moved from convulsive status epilepticus to non-convulsive status epilepticus? And like we talked about in the first episode, determining that can really be quite challenging. Some of the things that I look for at the bedside are hippus, meaning that the pupil is dilating and constricting, or that there's a persistent gaze deviation or subtle nystagmus, or even that the patient has sort of subtle motor findings. Their fingers are twitching a little bit, their cheek is twitching a little bit, looking for some of that rhythmicity. That would really push me to the fact that this patient is, continuing to have seizure-like activity, and someone I really need to intervene effectively and quickly, and anesthetics would be the next appropriate step. Versus a patient who's postictal, is really sleepy, but is coming back to baseline, is able to follow a simple command, kind of is groggy and maybe a little confused, but is showing real signs of kind of moving in the right direction. If you're at a center that has 24/7 EEG access, this is wildly helpful to actually have electrographic evidence of seizure, no seizure. Point of care EEG can be really incredibly helpful to just determine whether or not this patient continues to be in status. Because otherwise we really are depending on kind of subtle clinical findings, and it's hard to make a decision. But we know if we move to anesthetics, like how much do we need? So Salia, can you walk us through, like, is there evidence for one anesthetic over the other? And what are the side effects that I would need to be aware of?
Yeah, sure. Unfortunately, there's no evidence to say one is better than the other. I wish there was. Kind of what we talked about after your first line, benzodiazepine, everything is whatever works better for your patient based on drug-drug interactions, comorbidities, side effects, all the things that we mentioned to some degree during our first talk. But yes, there are a few options that we can talk about. I'm going to start with propofol, which I think is maybe one agent that a lot of people are more familiar with. I know propofol is an agent that we commonly use for sedation when we intubate people. In this case, when we're using it for status epilepticus, the dosing matters, as we talked about with other agents as well. For sedation, you most likely do not need to bolus people, but for status epilepticus, you absolutely have to bolus. The typical bolus dose that we talked about is, or we talk about, and it's in our chapter, is 1 to 2 mg per kg. And then you can start them on a continuous infusion as low as 30 to 50 mg per kg per minute, all the way to 200 mg per kg per minute. It can cause respiratory depression, but by this point, most of our patients, all of our patients are intubated. Hypotension, bradycardia, some of the common side effects of propofol that a lot of us know already. PRIS, or propofol-related infusion syndrome, is also something to think about, which is really a combination of rhabdomyolysis, renal failure, metabolic acidosis, and finally arrhythmias that can really be devastating. Usually happens in younger patients with trauma. And the idea here is that, we titrate per EEG, again, not RAS goal, just making sure that we have that goal clear and we communicate that with our team members. The second agent is midazolam. Remember that was our first line. We talked about how we give higher doses. We talk about usually midazolam being in the IM agent as 10 milligrams max dose of IM that we give as first line. But here you can actually start that as a continuous infusion in these refractory cases. We have to bolus again. The bolus dose is 0.2 milligram per kilogram. And the infusion actually starts at 0.05 mg per kg per hour, but it can go all the way to 2 mg per kg per hour. Again, you heard it right. So if you have a 50 kilogram patient, the dose can be as high as 100 milligrams per hour. Hypotension, again, bradycardia, those side effects come with, all the benzodiazepines, especially when you give them as a continuous infusion. Luckily, these patients are intubated, so we don't need to worry about that. And then finally, pentobarb is another agent that we commonly see in these really refractory cases. It's a barbiturate. We do load, again, patients with the fact that they can become hemodynamically unstable, but again, we can fix that. We'll talk about that later. The common bolus dosing that we talk about is 5 to 15 mg per kg, and then the infusion can go from 0.5 to 5 mg per kg per hour. Commonly known side effects: hypotension, bradycardia, risk of infection, risk of GI dysmotility, and such. So these are some of the agents that we typically see. And then there's 1 or 2 other agents that we can talk about later.
Awesome. And I think one of the things that's really hard about this is, what should the EEG goal be, right? So I think some of the difficulty in this is to understand, should I be aiming for complete burst suppression, meaning that the EEG has periods of inactivity and then burst of activity through that? Or am I just going for seizure suppression? And there's not great literature to guide this decision. I think you have to go sort of on a case-by-case scenario of where your patient is and how refractory they have been. One of the things that I see, kind of be a common misconception is, just like Salia, you were talking about, is many of these anesthetics do cause hypotension. And that does not mean that we should stop them. I mean, we can fix people's hypotension. So if you're finding a medication that works for your patient and you just need a little bit more, and a little bit more is causing them to be hypotensive, put in a line and start a pressor. I mean, that is expected for some of these patients. Really, what to do beyond that, I think, gets into sort of, unfortunately, trial-free data. It gets tricky to know what kind of anti-seizure medications that we should add on to these patients. And so I think quite frequently, these patients get put on multiple different anti-seizure medications, and it's not uncommon for them to be on 2 or 3 or even 4. And so, Salia, I was hoping you could walk us through what are some of those common drug-drug interactions that we should be aware as we start layering in these anti-seizure medications.
Yes, that's such a great point. So unfortunately, a lot of our anti-seizure medications are either CYP inducers or CYP inhibitors. And with CYP inducers, what happens is that you actually get lower concentration of the medications that are metabolized by that CYP. And with CYP inhibition, you get higher concentration of the drugs that are metabolized by the CYP. Phenytoin, for example, is a very strong CYP3A4 inducer, and valproic acid is a very strong CYP2C19 inhibitor. It also has some CYP3A4 inhibition. So the idea of giving, obviously, valproic acid and phenytoin together should be alarming to people, because you're going to have this combination of induction and inhibition that, to be perfectly honest, is impossible to overcome. You're going to be chasing levels day and night, and it's just not effective. So if you get to that point, you have to choose what agent really was the most effective and kind of stick with that. Besides that interaction, we also commonly talk about valproic acid and carbapenem as a class. This is not a CYP interaction. No one really knows how the interaction happens, but what we know is that by adding epenem, carbapenem, and those agents are imipenem, doripenem, ertapenem, all of them, and it's not specific to one of them only, something happens to the liver that the concentration of valproic acid will be undetectable, which is, as you can imagine, scary for someone who's in status epilepticus. To lose one of your agents is going to be very devastating. So at that point, the idea is that you have to think about an alternative. You either have to change your antibiotic, but if your patient's life depends on that carbapenem, then you have to probably think about changing your anti-epileptic. So the other piece that comes into play is that, what about anticoagulants? We use warfarin, not as much as before, but also DOACs. There are interactions, the CYP interaction is still there, so checking your drug-drug interaction software is going to be helpful. But one piece of advice is that phenytoin and valproic acid can interact with warfarin. Not only the CYP induction and inhibition, but also valproic acid and phenytoin, they're both very much protein bound. And warfarin is also very much protein bound. So the combination could mean that they're going to all compete with the same proteins. And that's going to make the active ingredient of the drug more available by kind of displacing it from the albumin or other proteins in the body.
Okay, got it. So like the big things to take away, phenytoin and valproate are not going to play nicely in the sandbox together. I should not be using them together. Pick one or the other. And then to realize that some of these older anti-seizure medications really do have so many drug-drug interactions. I feel very spoiled to have a neurocritical care pharmacist on rounds with me, who's constantly kind of finding these drug-drug interactions. But that valproate and carbapenem, man, like that can really, really burn you. The final thing that I thought was really exciting about this on-call chapter, given that it's continuously updated, there's now a section sort of summarizing some of the emerging literature that supports the use of ketamine for these refractory status epilepticus patients. So as you may or may not know, ketamine is an NMDA antagonist. So it has a completely different mechanism of action from some of the benzodiazepines and the propofol, which are more GABAergic drugs. So hopefully kind of thinking in, when to use this, and then kind of words of advice in terms of dosing strategy with this medication.
Sure. Yes. I think, as you said, the beauty of ketamine is its mechanism of action and how it's different from all the other anesthetics that we talked about. So, looking at our list, we talked about propofol, midazolam, and pentobarb, and all those three agents are GABA agonists. And we know that, by definition, status epilepticus means that you are having downregulation of your GABA receptors and upregulation of your NMDA receptors. So if you can find something that is going to act on those upregulated NMDA receptors and basically inhibit those, that's probably something that is reasonable to add on a little bit later. I think that's why a lot of people are finding this alternative or this option very attractive, especially when you failed your GABA agents. Just like other agents that we talked about, you have to be aggressive with the dosing. You have to load these patients. So the loading dose that we have is 0.5 to 4.5 mg per kg as a bolus dose. Again, you have to give that before starting your infusion. And the infusion can start from 1.5 to 10 mg per kg per hour, which again is a very high dose. I think the literature initially was suggesting lower doses, but now we have case reports and case studies looking at doses up to 10 mg per kg per hour. Also, unlike other agents, ketamine, if anything, can cause hypertension and not hypotension. And there is some concerns about arrhythmias. We also know that there's a hepatic metabolism, and we have to check LFTs for concerns with hepatotoxicity. But just like the other agents, you're really looking at your EEG for whatever target you decide to do, whether it's burst suppression, seizure control, full suppression, based on the goal and the target that you have in mind.
With ketamine, I think that there's been so much early literature that shows that this can be a pretty impressive reduction of seizure burden. And so I've been thinking about using this more and more when patients are kind of having some effect with a clear first choice for anesthetic, like whether that's propofol or midazolam. But I've been turning to this more and more frequently, and so it was cool to see that reflected. And then pharmacotherapy obviously forms the backbone of treatment for status epilepticus. Really looking at the pharmacology is how we most frequently, and sort of is all of the frontline approach to this. But one of the things that is emphasized in the chapter, and I think is really important to be aware of, is that there's a role for both neuromodulation and immunomodulation. Many of these patients who are coming in with this super refractory status epilepticus may have underlying encephalitis. And you can't expect to kind of beat the seizures if the underlying process is still going on. And so we could really get into the weeds about this, but I think it's better just to refer all the listeners to the chapter where you can learn a little bit more about how to utilize neuromodulation and immunomodulation to treat some of these really refractory cases that are quite challenging. All right, guys. Well, this has been really fun, and we will be back with another episode shortly.
Bye.
Bye.